All right, let's kick things off with two fundamental acid-base disturbances that are super high yield for your exams, and we're going to tackle them with a couple of classic clinical scenarios.
Okay, picture this. You've got a patient in front of you who's breathing way too fast, way too deep. You draw an arterial blood gas, an AGB, and their PaCO2, that's the partial pressure of carbon dioxide, is low, and their pH, it's high. You see this classic pattern. So what's going on here?
Boom. This is classic respiratory alkalosis. And really, the mechanism is super straightforward. When they hyperventilate, they're literally blowing off all their CO2. Less CO2 in the blood means you have less carbonic acid floating around. And what happens then? Well, the pH shoots up and you get alkalosis. It's a simple, direct chain reaction.
Okay, here's the exam pearl you absolutely need to know. The first thing that happens, the primary driver, is that drop in PaCO2. Then the kidneys kick in. They're like, whoa, the pH is way too high, so they start dumping bicarbonate, the HCO3-, to try and balance things out. So what do you see on the labs? You see both the PaCO2 and the bicarb are low. This trips a lot of people up, so lock this one in.
All right, let's flip the script completely. Now you've got a patient who's unresponsive. Their breathing is slow, really shallow. You get an ABG and, wow, the numbers are stark. The pH is plummeted to 7.22, and that PaCO2, it's shot up to 61. So what are we looking at?
You guessed it. This is textbook respiratory acidosis, and it's the exact opposite of what we just saw. The core issue? The patient just isn't breathing enough, they're not ventilating properly, so they can't get rid of their CO2. It just builds up and up and up in the blood. All that extra CO2 creates more carbonic acid, and boom, the pH takes a nosedive.
And here's the money slide, the big pearl. If you see a high PaCO2, your brain should immediately scream hypoventilation. This link is an absolute must-know. It's a one-to-one relationship you have to burn into your memory.
So knowing those gas patterns is huge because it's at the heart of managing emergencies like a bad asthma attack. So let's dive into that now. We're going to talk about how to assess these exacerbations and maybe more importantly, how to spot the really scary signs.
Okay, first up, a quick question to get us thinking. Let's say you have two patients with chronic asthma. One is coughing up this thick, goopy, tenacious stuff. The other has thin, watery sputum. Which one is the classic asthma picture?
Yep, it's that thick, sticky mucus. And there's a good reason for it. Think about it. The chronic inflammation in asthma causes the mucus glands to get bigger. That's hypertrophy. And you get way more goblet cells. And what do? They just pump out all this thick gunk. If you see watery sputum, you should be thinking about something else. Maybe just a run-of-the-mill viral cold.
And hey, while we're talking about sputum, let's nail down two other classic associations. If you see rust-colored sputum, you better be thinking pneumococcal pneumonia. And if it's pink and frothy, that is the absolute textbook description of pulmonary edema. You've got to know those. All right, let's change gears. We're in the emergency department now. A patient is having a really bad asthma attack. They're struggling to breathe. You've got options: labs, imaging, other tests. What do you do first? What's the right order of operations here?
Getting this sequence right is so important. Step 1. Before you do anything else, you need to know how bad this is. That means a peak expiratory flow. How much air can they actually move? Next, you get that ABG. Why? You're looking for signs of fatigue. Is their CO2 starting to climb? And then, and only then, do you even think about a chest x-ray. That's to rule out other nasty stuff like a collapsed lung or pneumonia. But you never delay assessment to get a picture.
Okay, this is probably the most important question in this whole section. When that patient is gasping for air, what is the one single sign that makes your blood run cold? The sign that tells you they're about to stop breathing completely.
It's a number, a PaCO2 of 50 or higher. Now this is super important. Think about it. Early in an asthma attack, what are they doing? They're hyperventilating, so their PaCO2 should be low. So when you see that number start to creep up towards normal, and especially when it hits 50, that's a disaster. It means their muscles are giving out, they're exhausted, they're about to stop breathing.
So here's the exam pearl, and it's a huge trap. A rising PaCO2 is not a sign of improvement. It's a sign of impending doom. Don't let a normalizing CO2 fool you into thinking they're getting better. They're getting worse, much worse. And you pair that with another terrifying sign, the silent chest. That's when you listen and you don't even hear wheezing anymore. Why? Because they're not moving enough air to make a sound. That's way worse than a loud wheeze.
Okay, to wrap things up, let's hit 2 more classic lung problems that are guaranteed to show up on your exams. The key here is going to be telling them apart.
All right, new scenario. Patient comes in, boom, sudden shortness of breath, and they have this sharp chest pain that's worse when they breathe in. So you rush them for a chest x-ray, and it's totally normal, clear as a bell. What's the life-threatening thing that has to be jumping to the top of your differential right now? This has to be a pulmonary embolism, or PE, and this is the absolute classic VQ mismatch. Remember, V is ventilation, air getting in, and Q is perfusion, blood flow. With a PE, a clot is blocking the blood flow, the Q, to a part of the lung, but the air, the V, that's still getting in just fine. So you've got this absurd situation where air is coming in, but there's no blood there to pick up the oxygen. That's why they get hypoxic. And because there's no pus or fluid filling the lung, the x-ray looks totally fine.
And here it is, maybe one of the biggest exam traps in all of medicine. A normal chest x-ray does not, let me say that again, does not rule out a PE. So burn this pattern into your brain. Sudden shortness of breath plus a normal x-ray equals think PE.
Okay, last case. This one's a gimme if you know the pattern. You've got a patient with a fever and they're coughing up gunk. You look at the chest x-ray and there it is, a solid whiteout, a consolidation that's perfectly contained to one single lobe. So what's the bug?
The number one cause here is good old strep pneumo. This bug is just famous for it. It causes this massive inflammatory response that just floods the air sacs, the alveoli, with pus and fluid. And it does it so completely that it fills up the entire lobe, which is what gives you that textbook lobar consolidation on the x-ray.
And this is a great little table for differentiating these patterns. So like we said, strep pneumo gives you that solid lobar pattern. But look at the others. Staph aureus, that's usually more patchy, kind of all over the place. And then you've got your viral pneumonias or mycoplasma. That's more of a hazy, diffuse look, in between the lung tissue. It doesn't really follow the rules of the lobes.
So let's wrap it all up with one last massive pearl. For your exams, if you see this triad, productive cough, fever, and a lobar consolidation on x-ray, your brain needs to fire off strep pneumo before you even finish reading the question. That pattern recognition is going to get you a lot of points. Lock it in.